This presentation is going to be a little bit different because the presentation itself is pre-recorded, and we will be showing you a portion of it, but then the full presentation is actually going to be available online. So it's kind of a bonus goodie that you can get some enrichment content, because there's a lot more recorded content that we weren't going to be able to fit into the main agenda. So definitely make sure you check that out on the Florida Asthma Coalition website. You can navigate to it from the event page. And Dr. Gregory will be with us briefly after this recorded portion for some live Q&A.
You do take the asthma educator certification. It is based on the NAEPP, the National Asthma Education Program guidelines, not the Global Initiative for Asthma. Okay, we've set the stage.
Okay, I'm going to go ahead and start Dr. Gregory's presentation.
Now let's take a deeper dive into SMART. Again, SMART is single, maintenance, and reliever therapy. So what is SMART? It is the use of a single inhaler containing a combination of an inhaled corticosteroid and formoterol, a long-acting beta agonist. And it's used for both maintenance and reliever therapy. And it is recommended by GINA, and it's also recommended by the NAEPP program for management in steps 3 and 4. I'm going to talk to you about that too. But both the 2020 NAEPP asthma update and the GINA documents recommend prescribing SMART for adults and adolescents with low-dose maintenance, formoterol, inhaled corticosteroid in step 3, and medium dose maintenance, ICS, inhaled corticosteroids and formoterol in step 4. This concept of SMART was first proposed by the International Pediatric Respiratory and Allergy Congress in 2001, so it's been around a long time. It's used in Europe and other countries too. Now this is the there's one of the charts for the stepwise approach for management of asthma, and you can see the preferred, and this is age 12 and above. The classifications are 0 to 5, 5 to 11, and 12 and above. So step 1, and it's based on a stepwise approach, and the higher the step, the more severe the asthma. So so step 2 would be like low dose inhaled corticosteroids and PRN, short-acting beta agonists. But when you go to step 3 and 4 is when we look at the combination inhaled corticosteroids with formoterol. This document also looks at 5 and 6, but we're going to focus on step 3 and 4 now. They do step 5, you use inhaled corticosteroids with the long-acting beta agonist plus other combinations like a long-acting muscarinic agent. And then this is 5 to 11, the dosage, and I wish we could go over this more, but it's here. I have provided these in your slides, and then there's 6 in your at the end of the presentation for you as well too. So expert panel report recommends that individuals ages 4 and older with moderate to severe persistent asthma, inhaled corticosteroid formoterol in a single inhaler be used for both controller and reliever. And then strong recommendation with high certainty of evidence for ages 12 and older, and then moderate certainty for ages 4 to 11. This is the global initiative for asthma, the GINA stepwise approach. Their document only has 5 steps, so instead of 2. But you can see step 1 or 2 for 12 and above still uses as needed low dose inhaled corticosteroid formoterol. So the global initiative for asthma says does not recommend using a short acting beta agonist as the reliever. Using the inhaled corticosteroid formoterol as a reliever reduces the risk of exacerbation compared to the short-acting beta agonist. And then step 3 is low maintenance ICS formoterol. Step 4, medium maintenance dose ICS formoterol. And then adding on that LAMA, or depending on what other considerations for treatment with more severe. And this is age 6 to 11. And you can see here low dose inhaled corticosteroids taken whenever SOB is taken, or daily low dose inhaled corticosteroid for step 1. And that is to prevent exacerbations and achieve control. And the global initiative for asthma also adjusts the treatment up and down depending on the needs of the child. This is just for your reference. I put the 2 together so you can compare and contrast exactly what is happening. But you can see step 2 and 3, strong recommendation from the NAEPP to 2020 using low dose formoterol or inhaled corticosteroid and formoterol, and then step 4 would be medium dose, and both is like this. So SMART, let's talk about this. The SMART regimen with budesonide and formoterol is approved in adults and adolescents aged 12 and older by regulators in more than 120 countries, and then for children aged 4 to 11 in a smaller number of countries. Over 45 countries have licensed this, and for as needed use in mild asthma, and over 120 have licensed this for prescription in moderate to severe asthma. One thing, just a little clinical pearl, outside the United States, many people call this MART instead of SMART. So they maintenance and reliever therapy. They don't say single. Just if you're traveling abroad, I want you to know. For us in the United States, a combination of budesonide formoterol is approved for daily use by the U.S. Food and Drug Administration for patients age 4 and above. For daily use, a maintenance, 2 puffs in the morning or 1 puff in the morning, 1 puff at night. But SMART regimens, regimens are not FDA approved for any age group. So, unfortunately. So which inhalers are SMART? Well, inhaled corticosteroid and formoterol. Currently, the combination of budesonide, formoterol, which is also known as Symbicort. I should say before I go on, I don't have any disclosures. I have no financial or anything with any of these inhalers that we're talking about today. But when I saw Symbicort, I just thought I better tell you that. So the combination is available in budesonide or formoterol. It's also in mometasone or formoterol, which we know as the brand name Dulera. Only the low dose, not the high dose. But there was no SMART studies using formoterol and mometasone. It was budesonide and formoterol only. So here we have the inhalers, Symbicort and 160 and 80, and we also, with Dulera, it's only 100. And the combination that contains inhaled corticosteroids, salmeterol, cannot be used. So Advair or Wexela is fluticasone and salmeterol. They cannot be used. So you cannot use salmeterol. You can only use formoterol for the long-acting agent. And those aren't used separately. They're used in combination therapy with the inhaled corticosteroid. And there were no SMART studies, again, using memetazone. Dosing, this chart is I hope this is helpful for you, but it looks at the puffs, step 3, step 4, maintenance and as needed, and the maximum. I always, when I write, I use SMART a lot, and when I write prescriptions for this, I don't use quite as high maximum total inhalations, because I want to know if they need that many reliever therapies or reliever therapy. I want to know about it. So this chart, I hope, is very helpful, but it looks at greater than 12 years old and then 4 to 11. So why SMART? Well, maintenance of inhaled corticosteroid and long-acting treatment with as-needed SABA can improve asthma, but it has been shown more effective than albuterol using just inhaled corticosteroid long-acting beta agonists, formoterol, and with budesonide and formoterol for maintenance and reliever. It's more effective and safer than as-needed SABA, short-acting beta agonists like albuterol. It reduces the risk for exacerbation compared to inhaled corticosteroids such as SABA, and the onset of formoterol is rapid. It takes about 5 minutes, but the advantage is there's a longer duration. So why, are you asking more, why SMART? A critical mass of data is indicated that combining the maintenance and reliever therapy often achieve better asthma control, decreasing the number of exacerbations. SMART approach augments anti-inflammatory coverage during the times when the symptoms are increasing and making airways more inflamed. So it's a protective thing and mechanism, and it can also be used for maintenance and rescue. So it only has a reliever. I use the term reliever. It only has so it improves adherence. And then it eliminates confusion too. How many, I have this inhaler, I have this inhaler, I have a green, I have a blue inhaler, all of this. So it really helps decrease confusion. SMART approach using formoterol budesonide is superior, looking at the evidence in patient with mild asthma using as needed inhaled corticosteroid formoterol reduces the risk. I was shown to reduce the risk of severe flare-ups by 60 to 64% compared to as-needed short-acting beta agonists. SMART was also associated with a 32% reduction of exacerbation compared to the same dose of inhaled corticosteroid LABA maintenance therapy, but using a short-acting beta agonist for reliever, with a 23% reduction of exacerbation compared to the inhaled corticosteroid long-acting beta agonist plus short-acting beta agonists. So with all of this evidence being said, bottom line is inhaled corticosteroid formoterol budesonide is superior in preventing the exacerbation, which is shown in clinical trials. There was a randomized control trial recently published that produced level 1 evidence in adolescents and adults, showing that it reduces the risk of severe exacerbations too across the spectrum of asthma severity. So when the same baseline maintenance was taken. And in children, there were limited studies or less studies. They're randomized to a very low dose of SMART, like 100 micrograms, had a 60 and 75% risk reduction of asthma exacerbations. One more piece of evidence I want you to have. I want to show you the Cochrane's. There was a Cochrane systematic review and meta-analysis of 9,565 patients with mild asthma treated with as-needed inhaled corticosteroid formoterol, and it had a 55% reduction in exacerbation and a 65% reduction in emergency room visits. And those patients treated as needed with formoterol, a 37% lower reduction risk of emergency room visits. compared to ICS and Jasava. So benefits, SMART therapy may take away some of the confusion about inhalers. It can help reduce inflammation and airway constriction. As needed has been shown to reduce the FeNO, or fractured exhaled nitric oxide, the indirect biomarker of airway inflammation. And it also is superior in preventing exacerbations, which I just talked about. We've seen reduced emergency room visits, hospital admissions, and best of all, the decreased reduction in systemic oral corticosteroids. It provides an anti-inflammatory treatment with when asthma and airway inflammation are at its worst. And even 1 day of modestly high short-acting beta agonists increases the risk of the return of an asthma exacerbation compared to using formoterol. There are some barriers, unfortunately. It's currently not approved by our FDA, and so that is very challenging. Sometimes you have to be creative. Many United States insurers, some of the insurance won't pay for it. The cost, or only pay for a 30-day supply, so for maintenance. So they could run out of medicine if they were using it for reliever and maintenance. The cost is higher. It's higher for inhaled corticosteroid, a long-acting beta agonist, compared to just an albuterol or short-acting beta agonist. And it is a new concept, so we're thinking a new concept too. And that can be challenging for patients. So just a few questions as we finish up. Can budesonide formoterol be used for exercise, to pre-treat before exercise and replace the short-acting beta agonist? And it's absolutely yes. Pre-exercise formoterol, or if it's just formoterol and budesonide, provides greater protection. We do not use formoterol by itself, and so it is budesonide and formoterol. It provides greater protection against exercise-induced bronchoconstriction compared to the short-acting beta agonist. It is, again, pre-exercise formoterol alone is no longer recommended because of the risk concerned of long-acting beta agonists. And based on available data, it would be reasonable to say that a patient receiving SMART who needed medication for exercise prophylaxis to take one inhalation of inhaled corticosteroid formoterol. I tell my patients about 15 minutes before exercise. In a school setting, they may not, there could be some confusion, so albuterol would be accepted. And then in a double-blind randomized control study, excuse me, I'm sorry, with mild asthma, they found that the use of low-dose inhaled corticosteroid formoterol for symptom relief and before exercise reduced exercise-induced bronchoconstriction at 6 weeks to an extent similar with that with regular inhaled corticosteroid. So who are our candidates for SMART? Well, they should require maintenance therapy, steps 3 and step 4. The main advantage is reduction of exacerbations, so we want to make sure they're appropriately, they are at risk for exacerbations, and they've had they've had oral corticosteroids, and it has been shown to be beneficial with those with a history of asthma exacerbation or frequent exacerbations. But SMART has not been tested in individuals for asthma and obesity or in pregnant women. And then patients who are not well controlled on current therapy, patients who are controlled on current therapy, there's no need to start SMART. They can continue on with their short-acting beta agonist. What about adherence? If they use SMART, will they adhere to their maintenance dosing, or will they just use it all the time as a reliever, as PRN, or as needed? In a 6-month trial of individuals with asthma and a severe exacerbation in the past year, participants in a randomized SMART study had fewer days without the use of inhaled corticosteroid long-acting beta agonist, or only one dose, and this was based on electronic inhaler monitoring. So teaching our patients, first we want to look, having a good treatment regimen, we see high satisfaction and adherence. If we have that, they're more likely to achieve better communication. As asthma educators, we know that, and shared decision making is imperative when we're working with our patients. SMART provides the option of rapid relief in a single maintenance dose, and it can reduce again the exacerbations. And then introducing SMART, patients may differ between those who have newly diagnosed asthma, so that is a consideration to teach our patients. So individualized approach is what we would use. You may need to change or get enough preventative medicine to control in case they run out as well. But and then the family should ensure this patient's school or any camps that when they're going to camp or any other activity. And it cannot, can SMART be prescribed with other inhaled corticosteroids? In patients with maintenance therapy, inhaled corticosteroids, long-acting beta agonists, they cannot use like fluticasone and salmeterol for maintenance, and then use inhaled corticosteroid and like budesonide and formoterol for relievers. So you cannot mix those two. There's lack of evidence. Big question, I know you have this, is SMART safe? So the NAEPP guidelines and advises clinicians should inform patients that studies involving SMART have found no difference in documenting harm between the two types of therapy. And then this conclusion is supported by pooled analysis of 6 randomized double-blind studies and 7 open-label studies using this. So yes, it is safe. And then what do we do about an asthma action plan? Well, we can help with that. There's a provision, I think this was done in Australia, but there's a provision of the asthma action plan. I can give you this if you want, or give you copies, looking at normal mode, asthma flare, and asthma emergency. So this document, or this one, does not have the red, yellow, or green, yellow, red, but it looks like it does, but their names are changed different. So we do have an asthma action plan. So some things to consider. As with all treatments, high patient satisfaction and adherence with treatment are more likely to be achieved through effective communication, education, and shared decision making, like we just had mentioned. Prescriptions of more than one type of inhaler that may occur, such as an inhaled corticosteroid long-acting beta agonist and an as-needed short-acting beta agonist, is associated with a lower likelihood of adherence and a greater chance of incorrect inhaler technique. So when they're using 2 inhalers, that increases their risk of non-adherence, and it also increases their risk of poor inhaler technique. Willingness and likelihood of adhering to a maintenance treatment should be considered, because poor adherence could result in the use of short-acting beta agonists alone, and then that could be overused. A written asthma action plan improves outcomes and is recommended in all patients. The approach to introducing SMART to any patient may differ depending on their needs and when they receive their diagnoses.
All right, I believe that we have Dr. Gregory with us. I've seen her.
Hi. Hi,
Hi, Dr.
everyone.
Gregory.
Hi. Hi.
So Wanda's got a mic in the main room and I'm on Zoom looking out at the event chat. I have not seen any questions come in yet in the chat. So I would say if anybody's got a hand up in the main room, let's start with our live attendees and we can go back and forth.
Is it open?
Hi, Dr. Gregory.
Hi.
Oh, there's the camera somewhere.
I can see you.
How are you dealing with maybe provider offices when there's like multiple providers, getting them to embrace the idea of smart therapy versus some of the other, like the previous prescribing where you have different inhalers on board? Is there something that you're seeing or best practice that you can share with our audience attendees to kind of how you kind of help the team make that transition so that they're comfortable with it and then the patients are going to be comfortable with it?
Right, that's an excellent question. And you know, we've done this albuterol for reliever therapy for 20 years or more, you know, and people in the old days, they used to use Atrovit and all that. So that's what we've always done. But the more we learn that this asthma is a heterogeneous disorder or disease, that treating the inflammatory response is key. So, and then just having the evidence. And I think the evidence-based practice, there's articles and there's the Global Initiative for Asthma that's updated every year. That's what is a good tool to help show them. But and then just telling your story, your success stories, if you have a patient or what, you know, that has come, but it's just a new way of thinking. And if we think about it, we are using, you know, with smart therapy, we use formoterol, and that's a long-acting beta agonist, but it shows to start working within 5 minutes. And so what I tell patients, and we can tell our colleagues too, we can tell our colleagues the muscles squeeze, you know, are constricting, and we can tell our patients those muscles squeeze and make you wheeze. But we're not treating that inside of the airway with the inflammatory response. So looking at that inflammatory response with like budesonide, or, you know, that is where, so the two working together as a team, we're going to take care of the inside and the outside of the airway.
I think this actually feeds directly into the question we just got in the chat, which is, are there plans to expand smart therapy to other brand inhalers?
That's an excellent question. Well, the studies just are shown with formoterol and so salmeterol, what we see, and I know I'm not supposed to say branded names, but the purple guy, so that purple dude, no. So with the salmeterol was not studied, and it doesn't have the quicker response what formoterol does. Formoterol starts to work in about 5 minutes. That's a good question.
So far, that's what we've gotten in the chat. Do we have another live question? We have like 1 more minute before we got to go into our next presenter.
So if someone's already set on that controller medication and they're using it twice a day as prescribed,
yes,
supposed to also use it before exercise as well, and how is insurance covering that if they're only a 30-day dose?
That's true. Yes, you would use 2 puffs in the morning, 2 puffs in the evening, and then, you know, 1 puff like 15 or 20 minutes before exercise. And it really is therapeutic. So sometimes with the insurance companies, what I personally do, I have it for a green zone, yellow zone, you know, type thing, so I can add more. So I can have coverage for that. And so like if they're on the 160 dosage, I mean, if they're on the 82 puffs, I could give them a 160 and that would last double long. So you kind of have to just play around with it. My email is on the slides at the end, and then I would be happy, and I know my presentation is longer, but I wanted you to have, and I think we're going to get to put it on the website so you can have the first part of it. Okay, because you have to have the understanding of, you know, I know we're all experts, you guys are all experts, but I just want you to have that basic name. But back to answer your question, it's individualized, and if you could do the 82 puffs and then, but prescribe the 160 and do one puff, and then you'll have double duty. So it's a lot of math.
So I'll reiterate the encouragement, definitely go online and find that full version of what Dr. Gregory prepared for us, because what you saw today was a slice. There is more. So we're giving you more goodies to check out online. And of course, you can also rewatch anything that you missed. All right, I believe that we are ready to turn it over to Wanda at this point. Oh, yes, absolutely.
Thank you, Dr. Gregory. Dr. Perpich, you want to say something very quick?
I just have one question. I know Massachusetts was successfully getting their state Medicaid to approve 2 supports that, per month, right? So you would have that coverage, so you'd have the rescue and both. Do you know if any other state, I mean, Florida's, we're in trouble because we've got all these Medicaid HMOs, and so how do you pick which one you kind of go after? Are you aware of any other states that have been successful at getting better expanded coverage like that?
No, Massachusetts is the only one I had. I'm following some other states, but I have not heard back. It's just that insurance is that obstacle that we have to overcome.
Okay, thank you.
Thank you. And I have my email. Please email if you need anything. Okay.
Yes, all that information and the entire presentation, the bonus presentation, will be on our website, the FloridaAsthmaCoalition.com. Okay. So just move ahead again, Dr. Gregory. Thank you so much for all the information and your accommodations to this kind of hectic schedule that we had.
Oh, my pleasure.
And to keep us on our toes in here.
Okay. Enjoy your conference.
Thank you, Dr. Gregory.